or next facet joint. Shot? And that's why the patient is here, to have his adjacent discs that are damaged and causing pain in his back and his legs. He's here to have those addressed. Shot? All right. So I'm aiming for the L4-5 shot. And he's wonderfully patient with me. Shot. Thank you. Shot. I'm encountering a very arthritic facet joint. So I'm going to have to start a little bit more lateral and try to get around this facet joint. Shot. And I can tell you already he has one of those spines that's pretty anterior. Shot. Because I'm having to really go at a steeper angle than normal to get there. I'm feeling the facet. So let's go with right there, shot, and then let's get an AP. So I'm now entering the foramen, heading towards the back of the disc at L4-5, just above his fusion, where there's a herniated disc. That's perfect. Perfect needle position. See how there's a screw at L5-S1, or I'm sorry, at S1 RS, that's backing out of the plate. You see that?
Yeah.
That's because the screw broke in half. And by the way, I did not do the fusion, in case you're wondering and you're watching. I don't do ALIF fusions because they're bad. But there's a lot of orthopedic surgeons that do them. And you know there are two screws. You see they're both broken. Show them both screws are broken. So I go through the back to fix people's with fusions. All right, Jordan, I think it's looking pretty good. Is our patient reliable? Shot? Any pain? Any pain? Nothing? Should I wait a few more minutes? Huh?
Yeah, another couple minutes.
All right. So let's go ahead and go from the other side. So remember, we're doing a bilateral L4-5. I'm going to approach the L4-5 from the other side. Shot. Maybe a little too high on my starting point. Any questions from our audience so far, Arias?
No current questions.
Can you show our audience the video of why do herniated discs cause back pain? What's the mechanism? Shot?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, Submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. And now you've had an opportunity to understand better why herniated discs cause so much back pain. And honestly, neck pain, thoracic pain, doesn't matter what part of the spine you're talking about, a herniated disc causes pain in the same mechanism, which is inflammation, no matter where it's located, in your neck, your back. I'm going for the L3-4 disc now, and I'm going for the L3-4 disc from the left side. Everyone agree, left L3-4? Let's just verify that. Left L3-4, bilateral L4-5. So we're always checking and double checking, because after all, we're operating on a human being. We want to make sure we're doing the right thing. So is he reliable at this point? The x-ray looks good. Let's go with an AP view. So I'm just entering the foramen once again at L3-4. So I want to check and make sure that we're nowhere near his nerve root on the x-ray. And it's looking really pretty good. So we're just below the disc. How you feeling? All right. You awake? All right. Do we have any questions from our audience while we're waiting?
No current questions.
Thank you. So the purpose of the Duke laser disc repair procedure is to debride the annular tear that is symptomatic, causing the back pain, and to decompress the nerve roots that are being pinched by taking the pressure off the nerve roots. By doing that, we can get rid of the back pain from the disc and the leg symptoms from the pinched nerves. Why don't you run the video, Arias, showing how the Duke laser disc repair works?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We are at a place now where we're going to advance our spinal needles into the spine. And once that's done, we'll be able to do the actual surgery. So I've passed the shot. I've passed the L4-5 left-sided needle. Shot. Just caught right up, there it is. I'm caught up on the superior facet. You awake?
My friend, you awake?
Just lay still. I need you to not move, okay? It's Dr. Duke. Lay still. All right. So Not yet, not yet. I need to finish L5-S1. Is that my most recent right there?
Yes, sir.
All right. So I'm looking at my needle at L4-5 on the right side. It's a little bit higher than I want it to be. So I'm going to come in and redirect and go a little bit lower. Shot. That's better. Shot. I'm right on the facet joint. And now I'm just slipping under the facet joint. Shot. Going right for that disc. Can you feel anything? What do you feel?
Back? Where are you feeling it? He's feeling it in the back.
Nothing down your leg, right?
He said, no, sir.
All right, you're doing great, by the way. We're almost done. I know it hurts, but this is those bad discs that we're here to fix, okay? You understand? All right. So, are you comfortable now? Now, you've watched 200 of my surgeries, didn't you? Why did you decide to come here for your surgery?
He said you're the best.
Because I'm the best. I appreciate that. All right. And how long have you had back pain for? How many years have you had back pain? How long?
3 months.
No, you had back pain before 3 months. 30 years. Okay. 30 years of back pain. When was your fusion done?
October 2000.
30 years.
2020 was the fusion.
So
2007.
lower back pain for 30 years. He had an ALIF, which you guys saw on the x-ray with the broken screws at S1. That was in 2007. Okay. And we're going to be performing the Duke laser disc repair at L4-5 and L3-4 to get rid of his back pain that he has in those areas. And then he also has some thoracic pain in the facets that we're going to address with the Duke plasma rhizotomy. Are you comfy?
Yeah.
All right.
Head still if you can for me, okay?
Yeah.
Please, thank you.
How bad is that on a scale of 1 to 10?
9.
Is that where you typically get your back pain?
Yes, my fault.
Is that where you, yes?
Yes.
All right, that's your L4-5.
Okay.
Was a 9 out of 10. Concordant. That means concordant means he gets it every day in that same spot. Is that better now?
Yeah.
You're going to get to go to sleep soon. Now notice how, guys, on this side, you see this, Arias, the dye coming out here?
Yes, we see it.
Because the dye went in one side into that L4-5 disc and now out the other side through the needle.
It's contiguous.
Yeah. Is that better?
Yeah.
All right. Who do you love?
That's all.
Who do you love?
All.
You're supposed to say Ghostbusters.
Yes, sir.
All right, Ghostbusters. And Duke Spine. All right. How bad is that on a scale of 1 to 10?
9.
Is that where you typically get back pain? All right, now we're going to put you to sleep. When you wake up, we'll be done with your surgery, okay?
Thank you.
And you'll have all your body parts fixed.
Thank you.
All right, count from 1 to 100 out loud for me. So folks, if you're watching, we just did what's called an evocative discogram, where we put a spinal needle into the disc that we're fixing. And we have to do it anyway as part of my surgery, but we do it, and when we're in there, we inject the dye. The dye is necessary to stain the herniated disc, the nucleus pulposus that's degenerated, because it's acidic. Acidic is not a sect of Jewish culture. It's actually acidic as in the pH is less than 7.4. Acidic, not Hasidic. And the dye will stain to the degenerated nucleus pulposus. So you're going to see it stuck inside the tear. The tear I'm talking about is the annular tear in the back of the disc. Okay, we've now placed our guide wire through this needle, and we're going to remove the needle so we can do his surgery. You don't want to have the guide wire move at all. Yep, go. And if the guide wire does move, then we're going to need to redo it. Okay, because you can't just stick the guide wire in there wherever you feel like it. It's put in a very specific place. Hey, lay still. I need you to count from 1 to 100. That's the only way we know you're asleep, when you stop counting. Keep going. That's going to hurt. It's medicine going in your vein. Why is it taking so long to get the propofol in? Did it just start going in now? Oh, okay. I have no problem with slow, but the pain starts when you start injecting the medicine, which I was wondering why there was a delay. Keep going. You're doing great. All right. So he's asleep now, and we're going to advance the dilator. What he was complaining about there for a second was the dilator is touching something called the fascia. And the fascia is basically a connective tissue layer above the muscle. And as it passes through the fascia has nerve fibers in it, pain nerve fibers. And so people can feel anything going through the fascia, and that hurts. It's interesting to note that the human body has pain fibers, but not everywhere, in very specific locations. As a neurosurgeon, we learn those locations in our training. And there's a lot of things in the body that doesn't have nerve fibers. Did you know the brain itself doesn't have nerve fibers? No pain fibers. So no pain nerve fibers. So you can actually literally operate on the human brain with the patient awake. Okay, next we're going to be putting our tube that we're doing the surgery with. And of course we're using our x-ray machine to guide. Okay? So the x-ray machine is used for two things. It's very important to remember. Number one, localization. What does that mean? It means knowing which disc you're dealing with. And number two is navigation, localization and navigation. Arius, do you mind writing those two words down in the dialog box? X-ray is used for localization and navigation. Now we're done localizing and we're done navigating. The rest of this disc will be done without the use of any x-rays. One of the advantages of Duke laser disc repair surgery you're watching is something we don't talk about a lot, but it's a very important advantage, and that is the less radiation is used during the surgery. With more traditional spine surgery like laminectomy, discectomy, the surgeon uses more radiation, especially with fusion surgery, where there's so much radiation used during the placement of the implants. So it's a much safer surgery doing the endoscopic for many reasons. No bleeding, no postoperative pain from the surgery itself, and minimal to no radiation. Plus you get to have your surgery done at Duke Spine Institute. Far safer to have your surgery here than a hospital. Hospitals generally are places where there's infections. Just think about it. If you have an infection in your body, where do you go? You go to the hospital. And for years, operating at the hospital doing spine surgery and brain surgery, I was always wondering why are patients with infections put in the same room as patients without infections. Doesn't make any sense. But that's exactly how it is. All right, any questions, Arius?
No questions.
Beautiful. I'm going to sharpen up the picture. There we go. So we are, which one is it? We're looking at the annular tear. That's the little white strands. And I'm going to start removing, we call this a debridement, where we're cleaning out the tear, removing the herniation and all the scar tissue as that we can. See the little orange crusts that are there? Those are calcium deposits within the tissue called dystrophic calcification. It's a sign of chronic inflammation and tissue damage. So this disease of herniated disc is damaged tissue is the annulus. All right. As we we'll put this on. It's not all the way down. No. Now it clicked. There's your tear. What a mess. Now look off to the right. You know what that bone is there, or what that structure is? At 2 o'clock, that's the end plate. That's the surface of the bone between the discs. And that specifically would be L4. Sorry, that would be L5, superior end plate. And the L4 is there on the left. Okay? So we're working between those bones. And this is where the disc is, between the bones, the surfaces of the bone, between the end plates specifically. End plates, E-N-D-P-L-A-T-E-S, for those of you interested. The disc is a soft structure located between the vertebral body end plates. We're not messing with the bones, we're just fixing the disc. This patient's going to go home an hour after their surgery. And this patient in particular is from Texas. The last patient was from Trinidad and Tobago, from the islands. I had a very good friend in medical school. Her name was Michelle. She was at USC with me, and her family was from Trinidad and Tobago. Of course, I had never been there at the time, still haven't. But her grandfather reminds me of the patient we just did surgery on. And they were a wonderful, close-knit family. They all lived in one house in Los Angeles. The mother, the grandfather, the kids, big family, 5 children. Anyway, I was helping Michelle with some of her studies, and I remember her grandfather telling me that if she passed her classes with my help, that they would have a giant party, and they would jerk a goat. jerk a goat, huh? I'm like, what does that mean? Jerk a goat. It turns out that jerking a goat is when the goat is I guess marinated in a sauce, jerk sauce, which, being from California, I didn't know what that was. But now that I've lived in Florida, I know what it is. Anyway, they barbecued a goat because she passed, and we had a big party, and it was wonderful. And I was very happy that she passed her tests. But they were from the islands, from Trinidad and Tobago. And that was my first friend I ever had from Trinidad and Tobago. I think she's doing primary care in Los Angeles. Her father was an OB-GYN, like my father, and he passed away, same as my dad, when I was about 17. So we had a lot in common. But I still remember the jerk goat. Now look at this pink stuff. This is inflammatory tissue that we talk about at the back of the disc in the superficial most part of the annular tear that causes all the pain because the pain fibers are here. The blue stuff is the herniated disc we talked about earlier, interposed nuclear interposed herniation. Interposed means between. Something that's interposed means it's between. So when you go to bed at night and you're laying there in bed in your sheets, your body is interposed between the sheets. So if you think about it, if you have a peanut butter and jelly sandwich, the peanut butter and jelly are interposed between the bread, right? Interposed is important when it comes to disc problems because it's the interposed herniation that causes all the pain. And that's what surgeons leave there. And that's why patients still have pain after typical microdiscectomy surgeries. Arias, any questions from our audience?
No current questions.
And you're sure we're broadcasting?
I'm certain.
Okay, very good. You guys know everything. I love it. So this is the herniation right here. You're looking at it. It's kind of wedged in at the back of those two end plates. You see that? You see the end plate on the right is the top end plate of 5. End plate on the left is the bottom end plate of L4. And this is the L4-5 disc, right? We're doing that one first. So I'm going to pull back a little more on the tube. Now what you're seeing at the top are little blood vessels and fat in the epidural space. Epidural space means the space behind the disc. That's where the nerves are that are traversing. We call it the traversing nerve root. Traversing means it's passing through. Traversing. When you traverse something, you pass across it or through it. And that would be the traversing nerve root, okay? By the way, I checked on our last patient. He's in the recovery area and he's having lunch with his daughter. It wasn't jerked goat. I was a little disappointed. It was actually fish. Fish and, what do you call it? Biscuits. But he's eating like a champ. He's ready to go home. Crystal, do they want to go home? It's okay. Huh? Yeah, I'm fine. I already saw him. He's doing good. But make sure he has an appointment to see me tomorrow. Yeah. Yeah, he was doing really good. Right? Yeah, he's eating like a champ. All right. So I'm having to go a little further back so I can get some more of this herniation with the laser. But you can start to see the different layers here. It's quite interesting. You've got the epidural fat. We're in the lateral recess, which is the space right behind the disc. And kind of now I'm removing that nuclear material, the interposed herniation. You can see the white fibers there where you transition from the annulus white fiber to the posterior longitudinal ligament. And the ligamentum flavum, which of course is the yellow ligament. Arias, any questions from the audience?
No current questions.
Very good. How was the Indian food, Arias?
I haven't gotten to try it yet.
You haven't tried it yet?
No.
All right. Grabber. So we're just about done here at this first disc. Once again, this is the L4-5. I'm going in with the grabber to see if I can get out any more herniation. I can't get any more, but I'll use the laser one more time, and then we'll be done with this disc. I'm very happy with the way things are progressing. You see that drop of oil right there coming out of the fat cells? Let's take a look. There's fat right there, a little blob of fat with little cells. Each one of those little things is a fat cell. Pretty cool. And then you can actually see the red blood cells, all right, coming out of this tiny little vein. Let's check it out. Each one of those red dots is a red blood cell. You're actually seeing the red blood cells. That's how zoomed in we are. I'm telling you, this is the best endoscopic system money can buy. It's a high definition. And each red blood cell, you guys see every red blood cell? They're like little tiny red things. Now notice the red blood cells are smaller than the fat cells. And there's a tiny little vein just pumping out its blood. Beautiful. All right. And you see what happens when I turn on the irrigation. All right, I'm going to tell you, if you don't ask questions soon, I'm going to have to start singing. I shouldn't say have to start singing. I'm going to pleasure you with my voice. Just ask my wife. It's not very pleasant. Maybe Chungo Stevens is in the audience. Arias, can you see if Chungo Stevens is there to ask some questions?
I'll have a look.
Chungo Stevens is one of our best fans who likes to watch these surgeries and comment. Right, Luis? Did you guys all get some Indian food? Yeah. All right. Where it's from? It's from one of our patients. Oh, the restaurant? All right, we're done here.
We have one question from our audience.
Sure.
It's on YouTube and says, "Why aren't you done with the surgery yet?"
Oh, why? Why am I not done with the surgery yet? If I had to guess, that would be a young whippersnapper of a person. I can almost hear the rebellious youth overtones in the comment, huh? Why am I not done with the surgery? Well, the reason is because we take our time and we do it right. And you can't rush good things in life.
Chungo Stevens says to go faster.
Well, Chungo Stevens. It's a good thing Chungo Stevens is not doing the surgery, right? Okay, that is disc number 1 out of 3. Let's bring our scope in. The scope we're talking about is the fluoroscope. So in spine surgery, we have different kinds of scopes. There's fluoroscope, microscope, endoscope. Scoping really means basically to create a window or portal through which to view things. All right, we are going to move up to the next disc, which has a huge tear in it, and that is the number 3-4. That's what we're going to be treating next. Shot? 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 All right, good. I need some pressure here. That's what you're supposed to be doing anyway. All right. Pressure on the muscle right there. It's not the skin incision that bleeds, it's the muscle that bleeds. Shot? Excellent. I don't think we need that. Do we have any other questions from the audience? Shot? We do need the patient asleep. Shot? Hold on, I'm not done. I need him asleep. Are you giving more medicine? So we did use the local, right? Shot? I'm fine. It just popped off. I think we're good. Let's see.
Yeah. Hey, can I have another guy wired, please?
What do we need another? Or?
I don't know.
Yeah, yeah. If you any question, change it. The guide wire wasn't the issue for me. It was just the it slipped.
See, no, 1 second, 1 second. Yeah, it is. Maybe with a towel.
Shot?
Can I have a towel or what?
Let me have the tube. Can you call 1299? Shot? All right. 1299. It's Sam.
Structure.
Oye, ¿cómo va? Shot? Yeah. All right, we're in like Flynn. Perfect. Ask Sam if she got my message. Huh? Yes. Are we going to get them on for tomorrow? Okay, so she has the MRI and everything that she needs? Good, thank you. That's all I needed to know. All right. By the way, if you know of someone with back pain or neck pain and they're suffering and don't know where to go for help, they can have a free review of their MRI at Duke Spine. We don't charge for it. And we give advice, a diagnosis, and recommended treatment. And it's a free 10-minute consultation. At least free in the currently. Someday we may have to start charging, but currently it's free. Nicely done, gentlemen. Good teamwork. I like it when a plan comes together. Yes.
We have 2 questions.
Okay. Who are they from?
One from Lori on YouTube. Lori asks, why don't more doctors know how to do this?
Why don't more doctors know how to do this, Lori? Great question. I could answer you, and you're not going to be happy with the answer. The answer is several parts. It's complex, but number one, you've got to know about technology to learn about technology, and most doctors don't even know this exists, okay? But why don't they know it exists? Why are they not being taught in their training? And that has to do with what I call the dark side of spine surgery. It's basically an effort on the part of the companies that make the metal, like that broken screw and plate you saw on this patient. Those companies don't want to lose the business of putting metal, and they're very powerful companies. What I mean by powerful is they have a lot of money. And you know the golden rule, the ones with the gold make the rules, okay? And they're the ones with the gold. And so they're controlling the educational system of spine surgeons in the United States. And they're basically making sure the surgeons that are being trained in the residencies in spine surgery, neurosurgery, are learning and performing fusions and artificial discs, which are highly invasive surgeries. Not bad surgeries by any means, but just far more invasive surgeries, and for the most part unnecessary. So there's a very strong financial disincentive for surgeons to do this surgery. They don't get paid as much, and the companies that make $10,000-$20,000 per surgery on the metal that goes into spines, they don't make any money on this surgery. There's no implants. There's no biologics. So we're cutting out the fat cat, and the fat cat doesn't like that. So it's a system that is over the last 40, 50 years has developed. And you may have heard of it before. You may have heard of something called the military industrial complex. Well, there's a spinal industrial complex too. And it's basically big business controlling what surgeons do. If you don't do fusions and artificial discs, you're not considered sexy. You're not considered cutting edge. You're not considered a top surgeon. So there's this stigmata associated with surgeons about doing what the industry wants you to do. By the way, there's the tear right there we're fixing. I was a fusion surgeon for many years, and it works very well when I do fusions. I can fix people's pain, but the truth is I can fix it like this too, just as well, without the screws and rods, without the loss of motion, without the scar tissue and bleeding, without the post-operative pain and need for opioid narcotics that are necessary for months after surgery, without keeping people out of work and laying them up for months or years after spine surgery like fusion. So the reality is that most surgeons don't know about it because they're not taught about it in their training, because the training centers are controlled by the implant companies. The implant companies donate tens of millions of dollars to neurosurgery education, and they basically control neurosurgery education. Neurosurgery and orthopedic spine surgery education won't happen without money from these companies sponsoring their meetings, sponsoring their journals. If you look in the journals for neurosurgery and spine surgery, you'll see every advertisement is for a device that's implanted in your body, most of them for treating pain. All those devices cost millions and millions of dollars, billions of dollars every year, and those companies control not just the advertising, but more importantly, they control the culture of spine in the United States and the world. So I'm going against the grain. Literally one man, and actually I'm following in the footsteps of another man, Dr. Tony Young from Phoenix, who was one of my most important mentors, actually the most important mentor, for doing lumbar endoscopic, and more importantly for taking on the big companies and this horrible, inappropriate, unnecessary, major types of surgeries on the spine culture. So I'm not very popular with them, and every opportunity they get, they try to hide my work and keep it from the eyes of decent surgeons that want to help patients and do less invasive treatment. That's the reality of it. It's a convoluted answer, but it's the truth. And the truth is, it's not going to get better until patients demand better. And that's why we do these broadcasts, to make people aware of better surgery options for them, so they don't have to be operated on with metal in their back or neck. Okay?
We had one more question.
Sure.
Question from Derek Olson on Facebook.
Derek. I never got an answer from Derek whether he's in Ireland. I think he is, right?
Derek asks, can you explain the difference between the cold water you use versus the warm water you had the other day?
Derek asks, Dr. Duke, can you tell us the difference between the cold water that you use for irrigation versus the warm water? And the difference is the cold water makes me happy and the warm water makes me very angry. How's that for the difference? Tongue in cheek. So the difference is the cold water cools the laser fiber at the tip, okay? We all have seen what happens when you drill and you keep drilling. The metal, the friction at the surface, the two surfaces that are moving, creates a frictional force. And the frictional force ends up generating heat. And that heat can actually melt steel. It can get so powerful. Well, with the laser, there's also heat generated at the tip, not because of friction, but because some of the energy, so without getting too technical, in physics, there's this thing called energy transformation, where you basically convert one form of energy into another. And if you study thermodynamics, which are the laws of thermodynamics govern transformation of energy from one form to another, you'll learn that all processes in our universe are inefficient when they transfer energy from one form to another. And some of that energy is lost as what's called heat, H-E-A-T, what we all know as heat, okay? So basically, as the laser is transferring its electromagnetic radiation energy, which is a form of physical energy, into breaking the bonds of the proteins in the disc, herniation, when it's doing that, some of that energy is lost as heat. And as a matter of fact, it's pretty substantial. So the tip of the laser can heat up to a high temperature. You could probably, without any circulation at all, we could probably get up to a couple of 100 degrees. Well, we don't want that, because then you're cooking the tissues, and we're not interested in cooking the tissues. We're interested in breaking up the bonds, basically a process called vaporization. So we don't want heat energy, and the cold irrigation helps cool the tissues that are being lasered, basically. So now when it's warm, it still works, but it doesn't work as well. So you know, if you want to have the perfect environment for this surgery, the perfect environment has cool irrigation. The less than perfect environment is warm irrigation. And the difference is a smile on my face versus a scowl on my face. If that makes sense.
Eric says he's from Minnesota.
Minnesota? Oh my, I'm so sorry. I thought you were in Ireland. All right, we like Minnesota. We like Ireland too. Next question.
No current questions at the moment.
Thank you, Derek, for asking. This is the outside of the bulge right here. And what makes up the bulge is the herniation within the tear. So it's not the tear that is a bulge, it's the herniation in the tear that's the bulge. And the herniation behind the tear that's the bulge. But that was the bulge. The bulge is now gone. Okay? And this is still a herniated disc right here. You see the blue color? That's nucleus pulposus. Nucleus pulposus. By the way, I think I've said this, nothing else binds to this blue dye except for herniated disc. Only herniated disc binds the blue dye. So everything else is white. All the white stuff or yellow stuff is not herniated disc. or at least not degenerated herniated disc, if that makes sense. So what are some of the white things? Well, some of it's annulus, some of it's posterior longitudinal ligament, some of it's scar tissue, some of it's bone, and even normal disc nucleus can be white. Normal nucleus is white. All right, so there we go. We've done most of this, about 90%. There's a tiny, tiny bit left. You can see the epidural fat. That's my indication we're done. We're all the way through the back here. We've cleaned the entire tear. I just want to get a few more millimeters and I'll be happy. What man is not happy with a few more millimeters? All right. That's it. Okay, so that's the L3-4. The nerve is up in the fat. Can't really see the nerve there because it's buried. Actually, let me just get that little bit of blue there. Sorry, false alarm. Arius, any more questions?
No current questions.
By the way, this tear, just for those of you kind of paying attention, that there is the surface of the vertebral body, okay, the end plate of L4. Notice how this tear is right above the surface. It's not closer to the L3 over there, it's right along the annulus that's sitting above the superior end plate of L4. So tears, I was asked a question about tears the other day. Tears can happen in the middle of the annulus, which is the most common, or it can happen sometimes right along the bone, where the annulus rips right off the bone, and then the jelly travels along it and out. Looking good. All right. Yeah, I don't see any more. So that should heal beautifully in time. People ask me how long does it take for the annular tear once you debride it to heal? The answer I tell everyone is 9 months to a year. And the truth is I don't know how long it's going to take, but I know it heals slowly because there's not much blood supply, right, to the disc. So tissues that don't have a good blood supply don't heal fast because you need blood supply to heal. Anybody know why you need blood supply to heal? Well, the reason is, number one, you need inflammation to heal. So you can't have inflammation without a blood supply. It's all right. Number two, you need nutrients. You need glucose. You need minerals. You basically need cells and nutrients to heal a tissue. And the way you get that is through blood supply. So once again, everything's all about blood supply. If you don't have good blood supply to a tissue in your body, that's why diabetics have these ulcers on their legs, because they don't have enough blood supply there to heal it. So the tissue just rots. They get gangrene, and the meat, the muscle, the skin, the fat, it all gets taken over by bacteria in an infection called gangrene. And then you have to cut their leg off because they don't have enough blood supply to heal. So you don't have that problem with the disc. Your disc will heal, but it just heals slowly. This is our last disc we're going to be fixing. I need to see the front of the spine. As soon as I'm getting close to being done, let's call Dr. Patel. Guys, ladies, Nurses? Skin knife? Not yet. I said as soon as I'm close to being done. That's all right. You guys have a lot on your mind. How is he? How is he? Good? Comfy? Sleeping nice? Saturating well? Anybody know what saturating well means? What saturating means is when you have enough oxygen, your blood cells will bind the oxygen at the iron group in the heme and at the hemoglobin, and it'll turn red, but it becomes saturated with oxygen. So when we say saturating well in medicine, we're talking about the patient's getting enough oxygen bound to their red blood cells. Yeah. It completes the tetramer. The tetramer is 4 porphyrin rings in the red blood cell. One of the best classes I ever took in college was taught by Dr. Paul Saltman at UC San Diego in the biochemistry department. And Dr. Saltman was a world famous biochemist and nutritionalist. But he also did research on something called metalloproteins. And metalloproteins are proteins that have metals attached to them. And the way you attach a metal to a protein, you don't directly bind the metal. You know, you don't form an amino acid covalent bond. The protein actually folds. So you have primary structure, secondary, tertiary, and quaternary. It's the tertiary structure of a protein that binds to a metal ion. And it's fascinating if you think about it, that we've evolved over the years to have proteins made that actually bind metals. And by binding the metal, we can actually do things like carry oxygen, right? So the fact that we evolved a protein in our bodies that can bind iron, therefore allowing us to bind oxygen, now we can become a very efficient multicellular organism. And we can conquer our environment. See, that's what kids should be talking about rather than shit like Instagram and TikTok and I don't know, whatever they're doing these days. You know, they should be marveling at science. And we've lost that in our society. When I grew up, if you were good in science and math, you were like, the schools would literally give you an award. You would be talked about. The girls got excited about guys that were smart. Guys got excited about girls that were smart. You know, intelligence was valued. Now, it's just about showing some skin and some booty and shaking it, you know? And that's what's valued. Or athletes, you know, throwing a ball around a court. But it's sad that that's the case because it took millions of years to get to the point where we appreciate knowledge. And then it took just 2 generations for that appreciation of knowledge and intellect to go away. And that's a big problem in America. I can tell you the Chinese value knowledge. The Koreans value it. A lot of the Asian cultures, ancient cultures, understand the value of knowledge. And it's rewarded heavily. Not in America. So, you got to do it for yourself. Hold on. Let's see. All right, we are in the L4-5 disc once again on the right side this time. How's my patient doing? breathing, ventilating, saturating? Good. Are you happy? If you're happy, then I'm happy. Arias, do we have any comments, questions?
No comments or questions.
Really disappointed that Chungo Stevens didn't make it today.
I believe he did, actually.
Oh, he did.
He,
Fantastic.
he asked why you weren't done with the surgery yet.
Oh,
and
right,
if you
right.
could move a bit quicker.
I see. That's right. All right. Well, for those of you who have watched a few of these surgeries, you see they're pretty much done the same. The real magic sauce is picking the right disc to fix. That's what I call the diagnostic part. And once you've done that, the rest is just a technical job, getting it right technically. By the way, look, left is the top of the L5 vertebral body. That's the bone there. And right is the bottom of the L4 vertebral body. And in between is the disc. A lot of compression right here. Berndes. He's real tight. He's real tight. You know what I mean, Joe Green? How can you tell? What does the heart rate do? So when they're light, where's the heart rate? Huh? So when they're light and they're feeling pain? So the heart rate goes up.
Coming out of the anesthetic.
All right.
Because the anesthetic is a cardiac depressant. So
Got it.
goes down, blood pressure goes down, respiratory rate goes down, everything is depressed.
Understood. My anesthesiologist is teaching me a little bit. I don't know all of it.
We have another question from Lori.
Yes, Lori.
Lori on YouTube says, define heal. Do the
Heal.
bone fuse themselves without a disc there?
Heal, heal, heal. Great question, Lori. Well, when we're talking about healing with respect to the human body healing, it's a very complicated process, right? Healing happens at multiple levels. There's physical healing, where the tissues mend. There's psychological healing, where people start to feel better about themselves and their life and start to forget about the condition they had. There's emotional healing, where basically closely related to psychological healing, where you start to have a more stable affect mood throughout the day because you're not suffering with pain. So when we talk about healing, when I talk about healing with the disc, I'm specifically talking about physical healing, not talking about emotional or psychological healing. I'm not an expert on emotional and psychological healing in these patients. It's a great question. It's a great question that someday we need to answer at Duke Spine. We need to study how our patients' lives are healed with the surgery, emotionally and psychologically.
Their mood shifts, too.
Huh?
Their mood shifts. You can see
Oh,
their
yeah. But for the,
right? Upbeat about
yeah.
life.
You know, is the glass half empty, half full? But what I can talk to you about right now is physical healing of the disc. And we're talking about the annulus fibrosis, basically the membrane that holds the nucleus in. That is what I say takes a year to fully heal. That's a piece of herniation, by the way, that didn't get stained blue. So what's going to happen is there's going to be a tissue layer that forms right there, right here, where I'm touching. It's going to go from one side of the bone to the other side of the bone. It literally will attach to the bone. And it will form a wall. And basically, it's the annulus that it's forming, the annulus fibrosis. So this wall that's formed after surgery with healing, physical healing, is made out of collagen. Collagen. Collagen is a fibrillary protein that your body makes and to repair tissues that are damaged. So your body is trying to make that collagen and repair the annulus. It just can't without the Duke laser disc repair. This surgery clears out. See the blue thing right here? That blue thing is a herniation of the nucleus. That's the nucleus pulposus. That's stuck. That's stuck in the annular tear, blocking the annular tear from healing. Literally blocking it. So by removing it, like I am right now, that's creating space for the annular tear to heal, for your body to heal the annular tear. So the Duke laser disc repair is an amazing surgery because we're letting your body heal naturally in a way that it's trying to do on its own but can't do because the herniation is stuck there. I'm removing that herniation from the tear, getting rid of the pain by doing that, but also letting your disc heal so you don't have more herniations in the future. That said, 1% of my patients will reherniate after the surgery, 1 in 100, and they'll have to have another surgery done. And when I looked at those patients and asked why, we can call Patel, the answer was almost always because they didn't follow my instructions. Okay? Don't ask me why they don't follow my instructions. People are the masters of themselves. They do their own thing. And some of them just, for whatever reason, think they know better than a surgeon. Now, I can tell you, I deal with these people all the time in Facebook because I'm on Facebook a lot. And you wouldn't believe how many people believe they know more than a neurosurgeon with 30 years of experience treating spines every day, dealing with them. Now, in their defense, I understand there's a lot of bad neurosurgeons out there, okay? But before you assume a neurosurgeon doesn't know as much as you about the spine, I strongly recommend you verify that fact first. Because the assumption should be they do know more than you until proven otherwise. Okay?
We have another question on YouTube.
In all fairness, they should be granted that deference.
RT says, why are the rhizotomy procedures not shown live?
Why are the rhizotomy procedures not shown off? RT, I could tell you, but I'd have to kill you. Why? Because they're top secret. They're going to be shown off, RT. The reason I'm not showing them is because I wanted you to ask me that question today. No, I'm just kidding. They're not shown because we're not ready to show them. We are going to be ready soon, and I'll explain why in the future. I think it's probably going to be another week or two. As a matter of fact, let me make it easy for you. In January, next month, we'll start showing them. Okay? I know that you all want to see them. I'm going to show them to you, but I need to wait till January.
We have a comment on YouTube.
Sure.
Chungo Season says he would divorce all his wives and husbands to pay for the surgery.
Oh, really? Interesting. Well, there you have it. That was from Chungo?
Correct. We have another comment from Facebook
Uh-huh.
coming from John Fox. John says, I'm disabled and wish Blue Cross Blue Shield would cover this procedure for my L4, L5, and SI.
John, you and me both, my friend. You and me both. There is a way to get the insurance companies to cover your surgery, and it is to fight with them to get them to do it. And we do that with Blue Cross. We really do. But unfortunately, we can't do it until your surgery is done. Now, that said, we are going to be going to trial against Blue Cross in the future unless they start more consistently paying for everybody's surgery that has it. And what I expect from the trial, and I can't promise it, but we expect a good decision from the judge or jury, and that their Blue Cross is going to be forced to pay for it. Now, just so you know, Blue Cross didn't pay for artificial discs at one point. They didn't pay for fusion at one point. And what happened was patients paid out of their pocket, they got the surgery done, and then they sued their insurance company to get them to pay for it. And this is a common thing done all over the United States. It's been done for everything: artificial discs, interspinous devices, fusions, you name it. Because the problem is the Blue Crosses of the world, they're focused more on just denying treatment to people so they can make more profits. Because remember, every dollar they save not paying a doctor or hospital goes into their pocket, into their bank account. I mean, actually, it's already there. It just stays there. So I think there will be a day when Blue Cross will pay for everybody's Duke laser disc repair. Don't hold your breath, though. I don't know when it's going to be. It could be a few years.
We have 2 comments from Janet Parker. Janet says, you have to fight. You have to be very persistent. Don't give up.
I agree with you 100%. Thank you for saying that. You have to fight. You have to be very persistent and don't give up. And I will say there is one more thing you have to be, and that is prepared. What I mean by that is Duke Spine has spent years preparing for this war against the insurance companies for this procedure. And we have really good data now to take with us. But it took many years to get that data. And I also took many years to find the right people on our team to team up with us. Most importantly, the patients. Can't fight without the patients. Need the patients. So the more patients that get this done, the better chance we have of winning. We have strength in numbers. Okay, I'm just about done. I need another, like 1 minute probably, and I'll be done. I just want to see if there's anything else back here I can get out. We're at the back of the disc now, and I'm literally attacking the last of the herniation. So I'm going to bring the laser in one more time, and then we should be done.
John says on Facebook, I hope you're right. I'm 61 and I'd have some good years left in me, and I don't want fusion.
I understand, and I appreciate your sentiment and comments. You're a smart person, John, and fusion is a bad, bad surgery. Honestly, if the fusion is done perfectly, which almost never happens, you'll have a decent result. But the problem is getting a perfect fusion. There's so few doctors that can do that. Of the few surgeons doing fusions, about, in my opinion, about 95% of them are not done perfectly well. Therefore, guess who pays that price? The patient. They suffer from a bad fusion.
We have a question from Lori on YouTube.
Sure.
Lori says, seems it would be cheaper for insurance companies to pay for your surgery rather than the more invasive surgery.
Hey, Lori. I love your comment. You are correct, 100%. So the only reason I can think of they don't do it is because if I tell 10 people that they need the laser surgery, all 10 will get it done. Nobody says no. No one says no. So the problem is with fusion, you see, when the surgeon tells you need a fusion done, what do? You don't get it done, right? So they actually save the money because people are so scared of fusions. They use their fear against you to basically not get treatment. That is how they work. They're very smart, these insurance companies. They've spent years developing their strategies to deny surgery. And it's always better when the patient denies their treatment rather than when the insurance company denies the treatment. So they just let you guys be scared of fusion and not get anything done. Out of 10 patients recommended for fusion, only one of them will actually get it done. So they know Even though fusion's more expensive, they may pay $100,000 for a fusion, or $200,000, let's just say. They may pay $50,000 for laser, but because all 10 will get the laser, that's $500,000 they'll pay out of 10 people. Whereas with fusion, they're only going to pay $150,000 because only one person will get it. They're not dumb. They've actually figured all this stuff out. And in the end, it's the patients who are suffering and the insurance companies that are profiting. And that has to change. That has to change. And the only way it's going to change is if people fight their insurance company to get the care they need, the best care. Okay? Great questions. We're done with this surgery. I'll show you the incision real quick in just a moment. I'm just putting some pressure on the muscle. Remember, the muscle bleeding is always vein, not artery. Because it's vein, it's 10 millimeters of mercury pressure versus 120 millimeters of mercury. So all I need to do is just do a little bit of pressure on the muscle and it stops the bleeding. If you don't stop the bleeding in the muscle, what happens is the patient will get blood in their muscle, just a little bit. We call that a hematoma. That will cause back pain and muscle spasms. It usually takes about 3 months for that to go away. Happened to me in a patient once years ago. And he had muscle spasms for literally 3 months after the surgery until it just dissolved away on its own and his body handled it. So since then, I've been very cautious about making sure that we don't get any bleeding inside the muscle. All right, take a look here at the incision. Arius, you see this?
Yes, we do.
That's a 1/4 inch incision. We did one on each side because he had bilateral pain. And we're going to move on to the plasma rhizotomy next. All right, you can go ahead and end the stream.